The objectives for this lecture are as follows. Discuss the present-day prevalence, physiological changes, and impacts on anesthesia with the obese patient. Discuss anesthetic techniques and considerations for the obese and morbidly obese patient. Obesity is a major health hazard both nationally and internationally. For the first time in human history, there are more overweight than underweight people. The World Health Organization estimated that as of 2005, 1.6 billion people were overweight and 400 million people were considered obese, and these numbers are projected to double by 2015. They also report that being overweight or obese is the fifth leading risk for global deaths. The Centers for Disease Control and Prevention released a study showing that deaths due to poor diet and physical inactivity has increased 33% over the past decade and will soon surpass tobacco use as the leading cause of death in the U.S. Obesity is a disease, and as such alters the normal physiologic functions of the body. While eating too much may be a substantial cause for obesity, the disease is much more complex than that. Certainly, when caloric intake exceeds caloric consumption over a prolonged period, fat will accumulate. However, there are poorly defined genetic, hormonal, and psychological factors that predispose some people to progressively worsening obesity, even though their dietary intake may not be excessive. Obesity is second only to smoking as a preventable cause of death. It is common for anesthetists to encounter these individuals in their daily practices. Since obese patients present numerous unique challenges due to their anatomic and physiologic changes, it is paramount for the anesthetist to be aware of these differences in order to safely and effectively care for these patients. The World Health Organization defines obesity as an abnormally high percentage of body fat. In contrast, overweight is classified as an increase in body weight above a standardized weight related to height. Clinically, body mass index, or BMI, is the most common method used to classify adult weight. It is defined as the weight in kilograms divided by the square of height in meters. BMI does not distinguish between fat and muscle mass. It is an indirect measure of obesity since it is calculated based on body weight from whatever source. Therefore, an individual with a high muscle mass may still be considered overweight or obese according to BMI. Obesity is associated with many pathophysiologic changes and comorbidities, and almost every organ system is affected in extreme obesity. Since obesity is a multi-system disease affecting all organs, there are a number of implications relevant to the conduct of anesthesia. Fat accumulation on the chest wall and abdomen reduces chest wall and lung compliance. Increased blood volume and red cell mass secondary to chronic hypoxia further reduces lung compliance. This decrease in chest wall and lung compliance leads to rapid shallow breathing and an increased work of breathing overall. These changes are exacerbated in the supine and Trendelenburg. The increased body mass and metabolically active adipose tissue leads to increased oxygen consumption and carbon dioxide production. Minute ventilation is thus increased to achieve normal capnia. There is reduced chest wall compliance of up to 30% due to the heavy chest wall, increased pulmonary blood volume, and splinted diaphragm. This reduction in compliance, together with increased respiratory demand, results in an increased work of breathing. Functional residual capacity is reduced primarily due to a reduction in expiratory residual volume. General anesthesia further worsens this reduction in FRC. Total lung capacity and vital capacity are also reduced. The reduction of FRC may lower lung volumes below closing capacity during normal tidal volume ventilation and results in small airway closure, which causes a ventilation-perfusion mismatch, right-to-left shunting, and hypoxemia. Chronic hypoxemia may lead to polycythemia, pulmonary hypertension, and eventually cor pulmonale. These patients are prone to hypoxia even when conscious and will desaturate particularly rapidly once apneic, as their oxygen reserve is reduced and oxygen utilization is increased, thus necessitating meticulous pre-oxygenation. Ideally, this should be done with the patient in a semi-erect position to increase the time to desaturation. Due to the reduced chest compliance and the shear mass of the chest wall, Higher inflation pressures are required to ventilate such patients. Such high pressures preclude the use of the laryngeal mask airway for ventilation in many cases. Hypoventilation will often occur when breathing spontaneously through a LMA or mask, and thus these techniques are not always recommended. Application of PEEP via an endotracheal tube is particularly useful in improving oxygenation by reducing small airway collapse. Extubation is usually best performed with the patient in the sitting position as awake as possible to allow maximal diaphragmatic excursion. Otherwise, the left lateral position is very safe initially, but abdominal splinting might subsequently lead to hypoxia. These patients need to be sat up once they are awake. Varying pathophysiologic consequences are associated with the anatomic distribution of body fat. In android or central obesity, adipose tissue is located predominantly in the upper body with a truncal distribution and is associated with increased oxygen consumption and an increased incidence of cardiovascular disease, including left ventricular dysfunction. In gynecoid or peripheral obesity, adipose tissue is located predominantly in the hips, buttocks, and thighs. This fat is less metabolically active, so it is less closely associated with cardiovascular disease. The prevalence of obstructive sleep apnea, or OSA, is increasing and is often associated with obesity. Obese patients may suffer from an upper airway obstruction syndrome that is classified into 3 categories: OSA, obstructive sleep hypopnea, and increased upper airway resistance are these 3 categories. At least 5% of morbidly obese patients will have OSA, particularly if they have an associated risk factor, such as a large collar size, greater than 16.5 inches, evening alcohol consumption, and pharyngeal abnormalities. OSA is characterized by frequent nocturnal apneic episodes. Apnea is defined as 10 seconds or more of total cessation of airflow, greater or equal to 5 times per hour of sleep, despite continuous respiratory effort against a closed glottis, in combination with a decrease in arterial oxygenation of greater than 4%. The disease is caused by passive collapse of the pharyngeal airway during deeper planes of sleep, resulting in snoring and intermittent airway obstruction. There are frequent episodes of apnea or hypopnea, snoring, and daytime symptoms including sleepiness, impaired concentration, memory problems, and morning headaches. Hypopnea is a 50% reduction in airflow for 10 or more seconds, occurring 15 or more seconds per hour of sleep, and sufficient enough to cause a 4% decrease in arterial oxygen saturation. The apnea-hypopnea index, which quantifies the severity of OSA, is the total number of apneas and hypopneas per hour. The total arousal index is the number of arousals per hour. The sum of the apnea-hypopnea index and total arousal index is the respiratory disturbance index. Physiologic abnormalities caused by CO2 retention at night and hypoxemia resulting from OSA include hypercapnia, pulmonary and systemic vasoconstriction, and secondary polycythemia from the recurrent hypoxemia. These result in an increased risk of ischemic heart disease and cerebrovascular disease. Right ventricular failure can occur from hypoxic pulmonary vasoconstriction, and respiratory acidosis is usually limited only to periods of sleep. The Stop-Bang questionnaire is a validated screening tool for OSA. This questionnaire incorporates 8 items, including snoring, tiredness, observed snoring, blood pressure, BMI, age, neck circumference, and gender. Its sensitivity and predictive value are both greater than 90% in individuals with moderate to severe OSA. If moderate to severe OSA is present, patients are often started on continuous positive pressure airway devices, or the dreaded CPAP. Institution of CPAP for even a few weeks prior to surgery has been associated with decreased pharyngeal tissue and markedly improved blood gases. Patients should be instructed to bring these devices to the hospital for use in the postoperative period. General anesthesia and the supine position result in atelectasis in morbidly obese patients. CPAP allows alveolar recruitment during inspiration and prevents further alveolar collapse during expiration. The signs and symptoms of OSA, such as snoring, daytime sleepiness, headaches, interrupted sleep, etc., should always be evaluated. It is helpful to interview the spouse, if available, to ascertain the presence of these signs, since the patient may be completely unaware of his or her disturbed sleep patterns. Avoid sedative premedication, since the maintenance of the airway might be difficult. Airway obstruction is very likely to occur in the postoperative period. So again, the patient should be positioned sitting up if at all possible, given oxygen, and the CPAP applied if necessary. Regional techniques and short-acting anesthetic agents are ideal to reduce postoperative drowsiness. OSA occurs most frequently during rapid eye movement or REM sleep, which predominantly occurs on the second night post-surgery. Consider nocturnal oxygen for up to 5 days following major surgery if available. Postoperative physiotherapy and incentive spirometry and early mobilization is vital. The obesity hypoventilation syndrome, or OHS, formerly called Pickwickian syndrome, is defined as severe obesity and hypercapnia, or a PaCO2 of greater than 45, in the absence of other causes of hypoventilation. This syndrome may result from long-term OSA and is seen in 5 to 10% of morbidly obese patients. Symptoms are similar to OSA, but patients with OHS suffer from daytime hypercapnia and hypoxia and pulmonary hypertension. Hypervolemia and cor pulmonale are also more common. Prolonged OSA also alters the control of breathing, leading to CNS-mediated apneic episodes, and this makes OHS patients extremely sensitive to sedatives and opioids because they rely on a hypoxic ventilatory drive. They are at risk for hypoventilation or even apnea when given 100% oxygen immediately following an anesthetic. The obesity hypoventilation syndrome, or OHS, formerly called Pickwickian syndrome, is defined as severe obesity and hypercapnia, or a PaCO2 of greater than 45, in the absence of other causes of hypoventilation. This syndrome may result from long-term OSA and is seen in 5 to 10% of morbidly obese patients. Symptoms are similar to OSA, but patients with OHS suffer from daytime hypercapnia and hypoxia and pulmonary hypertension. Hypervolemia and cor pulmonale are also more common. Prolonged OSA also alters the control of breathing, leading to CNS-mediated apneic episodes, and this makes OHS patients extremely sensitive to sedatives and opioids because they rely on a hypoxic ventilatory drive. They are at risk for hypoventilation or even apnea when given 100% oxygen immediately following an anesthetic. Obesity is associated with a number of cardiac risk factors. These include hypertension, ischemic heart disease, cardiomyopathies, cardiac failure, arrhythmias, sudden cardiac death, and dyslipidemias. Venous insufficiency, cerebrovascular, and peripheral vascular disease exacerbated by atherosclerotic processes may also be present. Total blood volume is increased in the obese individual, but on a volume to weight basis, it is actually less than in a non-obese individual. Most of this extra volume is distributed to the adipose tissue. Cardiac output increases with increasing weight by as much as 20 to 30 mils per kilogram of excess body fat because of ventricular dilatation and increases in stroke volume. The resulting increased left ventricular wall stress leads to hypertrophy, reduced compliance, and impairment of left ventricular filling, with elevated left ventricular and diastolic pressure and pulmonary edema. When left ventricular wall thickening fails to keep pace with dilatation, systolic dysfunction, sometimes called obesity cardiomyopathy, and eventual biventricular failure results. Obesity accelerates atherosclerosis. Symptoms such as angina or exertional dyspnea occur only occasionally because morbidly obese patients often have very limited mobility and may appear asymptomatic even when they have significant cardiovascular disease. Increased visceral fat is a cardiovascular risk factor even when the BMI is normal. Left and right cardiac failure can both occur. Venous return is also reduced. An obese abdomen will directly compress venous return from the legs. Once ventilated, higher inflation pressures and application of PEEP further reduces venous return, which may result in a fall in cardiac output. Obese patients are frequently inactive, and determination of impaired cardiac performance may be difficult. Blood flow to fat is 2 to 3 mils per 100 grams of tissue. An excess of fat requires an increase in cardiac output. To parallel an increase in oxygen consumption, this leads to a systemic arteriovenous oxygen difference that remains normal or slightly above normal. Intraoperative ventricular failure may occur from rapid intravenous fluid administration, indicating left ventricular diastolic dysfunction, the negative inotropy of anesthetic agents, or pulmonary hypertension precipitated by hypoxia or hypercapnia. Cardiac dysrhythmias may be precipitated by fatty infiltration of the conduction system, hypoxia, hypercapnia, electrolyte imbalance, coronary artery disease, increased circulating catecholamines, OSA, and myocardial hypertrophy. Frequent ECG findings seen in morbidly obese patients include low QRS voltage, multiple criteria for left ventricular hypertrophy and left atrial enlargement, and T-wave flattening in the inferior and lateral leads. In addition, there is a leftward shift of the P-wave QRS complex and T-wave axes, lengthening of the corrected QT interval, and prolonged QT interval duration. The ECG may also reflect evidence of myocardial ischemia or previous myocardial infarction. Cardiac dysrhythmias are also very common and are usually secondary to chronic hypoxia, hypercapnia, and fatty infiltration of the cardiac conduction system. Substantial weight reduction reverses many of these ECG abnormalities. Cardiac output rises faster in response to exercise or stress in the morbidly obese and is often associated with a rise in left ventricular end-diastolic pressure and pulmonary capillary wedge pressure. Similar changes occur during the perioperative period, which should prompt a low threshold for performing detailed cardiac investigations. Many obese patients have mild to moderate hypertension, with a 3 to 4 millimeter of mercury increase in systolic and a 2 millimeter of mercury increase in diastolic arterial pressure for every 10 kilograms of weight gain. Normotensive obese patients have reduced systemic vascular resistance, which rises with the onset of hypertension. Their expanded blood volume causes an increased cardiac output with a lower calculated systemic vascular resistance for the same level of arterial blood pressure. The renin-angiotensin system plays a major role in the hypertension of obesity by increased circulating levels of angiotensinogen, aldosterone, and angiotensin-converting enzyme. Obese patients have normal to increased level of sympathetic nervous system activity, which predisposes them to insulin resistance dyslipidemia, and hypertension. Obesity-induced insulin resistance enhances the pressor activity of norepinephrine and angiotensin II. Hyperinsulinemia further activates the sympathetic nervous system, causing sodium retention and contributing to the hypertension of obesity. Hypertension causes concentric hypertrophy of the ventricle in normal weight individuals, but causes eccentric dilatation in obese individuals. It is associated with increased preload and stroke work. The combination of obesity and hypertension causes left ventricular wall thickening and a larger heart volume. Therefore, there is increased likelihood of cardiac failure. As little as 5% reduction in body weight leads to a significant reduction in activity of the renin-angiotensin system in both plasma and adipose tissue, contributing to a direct reduction in the blood pressure. Obesity increases intra-abdominal and intragastric pressures, and the lower esophageal sphincter is more relaxed. Gastric emptying is faster with high energy content intake such as fat emulsions, but because of larger gastric volumes, up to 75% larger, the residual volume is increased. Both the faster gastric emptying and the larger gastric volume can be partially reversed by weight loss. Hiatal hernias and gastric reflux are more common. A positive correlation exists between obesity and frequent gastroesophageal reflux symptoms and esophageal erosions. The combination of hiatal hernia, gastroesophageal reflux, and delayed gastric emptying, coupled with increased intra-abdominal pressure and a high volume, low pH gastric content, puts the obese at risk for increased incidence of severe pneumonitis should aspiration occur. The volume and acidity of gastric contents is often increased, and as stated earlier, intubation might be difficult. Despite an 8-hour fast, 85 to 90% of morbidly obese patients have gastric volumes greater than 25 mils, increasing their risk for pulmonary aspiration. The high prevalence of non-alcoholic fatty liver disease and cirrhosis necessitates careful assessment for pre-existing liver disease in patients scheduled for surgery. Obesity is a major risk factor for non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Features of non-alcoholic fatty liver disease include hepatomegaly, elevated liver enzymes, and abnormal liver histology. Peculiar morphologic and biochemical abnormalities of the liver that are associated with obesity include fatty infiltration, inflammation, focal necrosis, and cirrhosis. Fatty infiltration reflects the duration rather than the degree of obesity. Histologic and liver function test abnormalities are relatively common, but clearance usually is not reduced. Abnormal liver function tests are seen in up to 1/3 of obese patients who have no evidence of liver disease. Weight loss results in sustained improvement in liver enzymes in direct proportion to the extent of weight reduction. Despite these histologic and enzymatic changes, no clear correlation exists between routine liver function tests and the capacity of the liver to metabolize drugs. Morbidly obese patients who have undergone intestinal bypass surgery have a particularly high prevalence of hepatic dysfunction and cholelithiasis, which is also common in the general obese population and of which abnormal cholesterol metabolism is partially to blame. Non-insulin dependent diabetes and its associated microvascular and macrovascular changes, which is caused by insulin resistance and inadequate insulin production, is much more common in the obese. More than 10% of obese patients have an abnormal glucose tolerance test, which predisposes them to wound infection and an increased risk of myocardial infarction during periods of myocardial ischemia. Exogenous insulin may be required perioperatively, even in obese patients with type 2 diabetes, to oppose the catabolic response to surgery. Adult-onset diabetes occurs 7 times more frequently in obese than in non-obese patients. Subclinical hypothyroidism occurs in about 25% of all morbidly obese patients. TSH levels are frequently elevated, suggesting the possibility that obesity leads to a state of thyroid hormone resistance in peripheral tissues. Hypothyroidism may be associated with hypoglycemia, hyponatremia, and impaired hepatic drug metabolism. A reduction of thyroxine is seen with a decrease in BMI. Hypercholesterolemia, gout, osteoarthritis, back pain, hepatic impairment, gallstones, abdominal hernias, and breast and endometrial malignancies are all more common in the obese. Obesity is also associated with glomerular hyperfiltration as evidenced by increased renal plasma flow and an increased GFR. With prolonged obesity, there may be a loss of nephron function with further increases in arterial. The risk of pulmonary embolus and DVT is doubled in the obese. Other causative factors for this increase include hypoxia-induced polycythemia, cardiac failure, decreased fibrinolysis, and immobilization. Venous thromboembolism is one of the most common causes of postoperative mortality in the morbidly obese. Obese patients have several risk factors for venous thromboembolism, including polycythemia, post-op immobilization, increased platelet function, diabetes, and hypercholesterolemia. Sequential compression stockings should be applied, and early ambulation should be encouraged after surgery if at all possible. Obese patients have numerous pathophysiologic conditions which alter the pharmacokinetics and pharmacodynamics of anesthetics. Histologic abnormalities of the liver are common in the obese, but drug clearance is not usually affected. Renal clearance of drugs is increased in obesity because of increased renal blood flow. As a result of both increased GFR and increased tubular secretion, drugs such as cimetidine and aminoglycoside antibiotics that depend on renal excretion may require increased dosing. Obese individuals have an increased amount of fat compared to non-obese individuals of similar age, height, and gender. The increased fat mass increases the volume of distribution of highly lipophilic drugs. The apparent volume of distribution for a fat-soluble drug, such as thiopental, is increased because of the lipophilic nature, and therefore the dose should be increased, but a raised volume of distribution also results in reduced elimination, resulting in prolonged effects. Slow emergence after use of fat-soluble volatile agents may be due to central sensitivity as much as due to delayed release from adipose stores. If available, use relatively insoluble agents as much for speed of reversal as to reduce postoperative drowsiness. Increases in cardiac output, total blood volume, and changes in regional blood flow may affect peak plasma concentration, clearance, and elimination half-life of many anesthetics. In the obese patient, volume of distribution, binding, and elimination of drugs are often unpredictable. This uncertainty necessitates that the anesthetist pay more attention to the clinical endpoints of the drug, such as loss of verbal contact, tachycardia, etc., rather than focusing specifically on whether the dose is ideal. Some pharmacological certainties are a reduction in total body water, higher fat mass, relatively higher lean mass, higher GFR, increased renal clearance, and normal hepatic clearance. Morbidly obese patients are especially prone to the respiratory depressant effects of opioids. Generous administration of opioids should be avoided to reduce the likelihood of post-op ventilatory depression after extubation. Opioids that are highly lipophilic and have a large volume of distribution should be avoided in these patients. In theory, the large volume of distribution would suggest that loading doses of opioids should be dosed based on total body weight. Recent studies suggest that fentanyl clearance increases linearly with pharmacokinetic mass. Longer-acting opioids, such as morphine and Dilaudid, should be avoided because of risk of severe postoperative ventilatory depression. Fentanyl, Sufenta, and alfentanil are preferred. Desflurane has been advocated to be the inhalational agent of choice in obese patients due to its low lipid solubility. It is generally believed that saturation of the adipose tissues by more lipid-soluble agents, such as sevoflurane and isoflurane, can prolong emergence from anesthesia. However, Several studies have failed to demonstrate any significant differences in time of emergence or time to PACU discharge with any of the commonly used inhalational agents. The concentration of all these agents decreases rapidly from the well-perfused brain and lungs, and any inhalational agent can be used safely and effectively in the obese population. Propofol and thiopental have a very large volume of distribution in obese patients. Clearance of these agents is also increased. Maintenance infusion should be given based on total body weight, but induction doses based on total body weight could result in cardiovascular depression. Cardiac output is a major determinant of the early distribution kinetics of these agents. Therefore, induction doses should be based on lean body weight. Pseudocholinesterase levels increase with increasing obesity. High doses of succinylcholine have been shown to be effective for use during RSI. Non-depolarizing muscle relaxants are weakly lipophilic, limiting their distribution to adipose tissue. There is no clinical advantage to any of the commonly used non-depolarizing neuromuscular blockers. These blockers should be based on ideal body weight. The degree of relaxation should be monitored with a nerve stimulator. Neuromuscular blockade must be completely reversed before extubation. Prior to extubation, it is suggested that the patient have a respiratory rate of less than 30 breaths per minute and a maximal inspiratory force of at least -25 to -30 centimeters of water, a vital capacity of 10 to 15 mils per kilogram, and a total volume greater than 5 mils per kilogram. If the patient has baseline respiratory compromise, was a particularly difficult intubation, or does not meet all extubation criteria, a delayed extubation might be warranted in order to allow the patient adequate time to recover from the effects of general anesthesia. Good regional anesthesia may reduce opioid and inhalational requirements intraoperatively in thoracic and abdominal surgery and may be used as the sole technique in peripheral surgery. However, it is technically harder because of the loss of landmarks, the increased movement of the skin, and the need for longer needles. Initial failure is higher in the obese. The sitting position is usually easier for spinal and epidural placement. In the absence of clear bony landmarks, the 7th cervical prominence and gluteal cleft will indicate the midline, and patients also can assist by verbally redirecting the needle when it strikes the lamina. It is relatively uncommon for the epidural space to be more than 8 centimeters deep. Leave extra catheter in the space as it may be subject to drag as the flexed patient relaxes. Due to the engorged extradural veins and extra fat constricting the potential space, less local anesthetic may be needed for epidurals. 75 to 80% of the normal dose may well be sufficient. As we have mentioned, the supine position causes a reduction in FRC, a significant ventilation perfusion mismatch, and increases in cardiac output and pulmonary artery pressures. Obese patients have an increased work of breathing 2 to 4 times greater than normal. An increased chest wall mass decreases chest wall compliance and diaphragmatic excursion. The reverse Trendelenburg position, a semi-recumbent position of 35 to 40 degrees, reduces abdominal pressure on the thorax by allowing the diaphragm to fall, and this will maximize your FRC. The safe apnea time is only 1 to 2 minutes in supine obese patients, but is doubled if the obese patient is in reverse Trendelenburg or the semi-recumbent position. The Trendelenburg and lithotomy positions further reduce FRC, and both of these positions should be avoided if the patient is breathing without mechanical assistance. If surgery must be performed in the supine, Trendelenburg, or lithotomy position, it is safest to intubate the trachea and control ventilation with an FiO2 between 50 and 100%, and tidal volumes of 10 cc's per kilogram of ideal body weight. The reverse Trendelenburg position is the preferred position for morbidly obese patients before induction of anesthesia and during recovery in the postoperative period. Supplemental oxygen should be administered immediately after extubation. Obese individuals have a marked reduction of FRC, making them prone to rapid hemoglobin desaturation during periods of apnea. The airway must be secured quickly to minimize the apneic period that follows the administration of a muscle relaxant. Obese patients should be pre-oxygenated with 100% oxygen for a minimum of several minutes to maximize oxygen reserves prior to induction of anesthesia. Prior to intubation, towels or folded blankets under the shoulders and head compensate for the exaggerated flex position of posterior cervical fat. The object of this maneuver, known as stacking, is to position the patient so that the tip of the chin is at a higher level than the chest to facilitate laryngoscopy and intubation. The head elevated laryngoscopy position, or HELP, is a step beyond stacking. It significantly elevates the obese patient's head, upper body, and shoulders above the chest to the extent that an imaginary horizontal line connects the sternal notch with the external auditory meatus to better improve laryngoscopy and intubation. This position improves the view of the larynx and is associated with successful tracheal intubation in many morbidly obese patients. To facilitate proper HELP placement, the preformed troop elevation pillow may be used in place of folded towels or blankets. The advantage of this preformed pillow is that it can be pre-positioned, inserted, and removed much faster and with much less effort than that required to build and dismantle a ramp made from blankets and towels. An inflatable multi-chambered pillow may more easily facilitate HELP placement without the need for additional lifting of the morbidly obese patient. During laparoscopy, the carbon dioxide pneumoperitoneum can result in increased peak airway pressure, decreased tidal volumes, and hypercapnia. Increasing the tidal volume is not recommended, as larger tidal volumes may increase peak airway pressures and cause barotrauma. Minute ventilation can be safely adjusted by increasing the respiratory rate and smaller tidal volumes and PEEP added. However, PEEP may worsen hypoxia by decreasing cardiac output. All parameters usually return to normal once the pneumoperitoneum is relieved. After laparoscopic procedures, most patients will have discomfort from the gastric distension caused by the CO2 pneumoperitoneum. This discomfort is generally not responsive to opioid analgesics, and patients should be informed of this possibility prior to the start of surgery. Patients who use CPAP at home should be instructed to bring their equipment to the hospital for use in the PACU. General anesthesia and the supine position result in atelectasis in morbidly obese patients. CPAP allows alveolar recruitment during inspiration and prevents alveolar collapse during expiration. Morbidly obese patients are prone to neurologic injury, pressure sores, and rhabdomyolysis. All pressure points must be carefully padded, and the neck and extremities must be maintained in a neutral position. Most operating room tables have a weight limit of approximately 200 kilograms and can often be too narrow for these potentially very wide patients. Overflow from the side of the table increases the risk of pressure sores or nerve damage, as the patient is wedged into place to ensure they do not fall off. This may also interfere with the tilting function of some tables. Special equipment may need to be ordered for the very obese patient. Operating tables capable of holding up to 455 kilograms with a little extra width to accommodate the extra girth are available. The sheer mass of the patient means they are harder to position and present an increased risk to the OR staff during handling and lifting. For this reason, morbidly obese patients are at risk for peripheral neurologic injury from improper positioning and padding. Strapping obese patients to the operating table in combination with a malleable beanbag helps keep them from falling off. Particular care should be paid to protecting pressure areas because pressure sores, neural injuries, and rhabdomyolysis may occur. Brachial plexus and lower extremity nerve injuries are frequent. Carpal tunnel syndrome is the most common mononeuropathy after bariatric surgery. During prolonged procedures, muscle tissue can be damaged, which can lead to rhabdomyolysis. In the PACU, the patient may complain of muscle tenderness in the dependent muscles. The presence of epidural analgesia may mask this symptom. Due to associated myoglobinuria, the urine can turn a characteristic tea color. If untreated, rhabdomyolysis can lead to hyperkalemia, hypocalcemia, renal failure, disseminated intravascular coagulation, cardiac dysrhythmias, and cardiac death. An elevation in serum creatinine phosphokinase above 1,000 international units is considered diagnostic of rhabdomyolysis. Perioperative fluid replacement, proper positioning and padding, and early ambulation can help prevent this complication. Let's review some of the key points from this lecture. Non-alcoholic fatty liver disease and elevated liver function tests are seen in a significant number of obese patients. Despite these histologic and enzymatic changes, no clear correlation exists between abnormalities of routine liver function tests and the capacity of the liver to metabolize drugs. Rhabdomyolysis is sometimes seen in morbidly obese patients undergoing prolonged operative procedures. Unexplained elevations in serum creatinine and creatinine phosphokinase levels, or complaints of buttock, hip, or shoulder pain in the post-operative period may indicate that rhabdomyolysis has occurred. Patients scheduled for repeat bariatric surgery may have long-term vitamin and nutrient deficiencies, which may lead to acute post-gastric reduction surgery neuropathy, a polynutritional multisystem disorder characterized by protracted post-operative vomiting, hyporeflexia, and muscular weakness. Morbid obesity is a major independent risk factor for deep vein thrombosis and sudden death from acute postoperative pulmonary embolism. Subcutaneous heparin reduces the risk of deep venous thrombosis. However, low molecular weight heparins are currently popular for thromboembolism prophylaxis because of their bioavailability when injected subcutaneously. Neck circumference has been identified as the single best predictor of problematic intubations in morbidly obese patients. A larger neck circumference is associated with the male sex, a higher Mallampati score, grade 3 views at laryngoscopy, and obstructive sleep apnea. Particular attention should be paid to the airway in obese patients because they are often difficult to intubate as a result of limited mobility of the temporomandibular and atlanto-occipital joints, a narrowed upper airway, and a shortened distance between the mandible and sternal fat pads.